welcome back to the lecture. So we'll continue with the important disease of the brain. So the first what we're going to discuss about the cerebrovascular accident and the hemorrhage. So the first is the most important is the extradural hemorrhage. As we discussed the brief anatomy of the brain and the meninges. So between the skull and the meninges, which is the dura mater, if the blood gets accumulated, is called as extradural hemorrhage. Now, what's the point to note is that the meninges are attached to at certain points to the skull. Okay, so we have the dura mater here, which is attached at certain points to the skull. Okay, and these are quite tight attachments. So whatever bleeding is there, it will be between those two attachments, as you can see. Okay, so that's why you get an convex shaped opacities, or this is called as the density, hyperdensity in case of CT. What we observe is an convex shaped uh, hyperdensity between the skull and the brain parenchyma. This is of the extradural hemorrhage. That's the first point to note. Second important point to note, it's usually arterial bleed. Okay, so we have the middle meningeal artery, which is one of the important arteries, which pass through the just below the near just above the temples, so temporal area of the skull. So which is a branch of the external carotid artery. So middle meningeal artery is the one which is usually affected in extradural hemorrhage. So usually there's history of trauma to head, rupture of the middle meningeal artery. There's a brief loss of consciousness, which is followed by a delayed deterioration. This is called lucid interval. You might have come this term in forensic medicine, lucid interval. So lucid interval is a period of stability in between two periods of loss of consciousness. So initially there is initially a brief loss of consciousness, followed by some stabilization in the sensorium, followed by subsequent recovery. So this is called as lucid interval. Now, the patient may present with confusion, aggressive, it may become drowsy. Investigation of choice if suspecting extradural hemorrhage, usually following a road traffic accident, is CT brain, and treatment of them is stabilization followed by the evacuation of the hematoma by surgery. Next comes subdural hemorrhage. Subdural means hemorrhage which is below the dura, that means between the dura mater and the arachnoid mater. Now, the most important causes here is usually elderly person with a trivial fall. Okay, do remember, in contrast to extradural hemorrhage, which requires certain force for creating a bleed, for example, motor vehicle accident or severe trauma on the head, the subdural hemorrhage requires minimal trauma. Okay, so especially elderly who have some kind of brain atrophy, there is subdural space may be present. Okay, generally the dura mater is quite closely attached to arachnoid mater, and there is no subdural space. Whereas in these patients who have got some pathologies, who have brain atrophy, who are elderly, there could be some subdural space on which even a minute trauma can produce bleed. Second important thing what you have to remember, it's a venous bleed. So it's a very slow onset and a slow progressive disease compared to extradural hemorrhage. Extradural hemorrhage is usually sudden and acute. So here the patient might have forgotten the trauma. Patient suddenly comes with altered personality. He may go to a psychiatry, visit a psychiatry consultation. He comes with a drowsiness, may visit a physician or a neurophysician. So the presentation is not acute, and the patient may not remember the trauma. It's only on evaluation when you do a CT brain, you see this extradural, the subdural hemorrhage, and then you ask for any trauma, any history of alcoholics who may not be able to understand the trauma, or may not be able to identify or remember the trauma when they are drunk. So bleeding here is from the venous side. These are bridging veins between the cortex and the venous sinuses. So the patient can present slowly progressive headache, fluctuating consciousness level, intracranial pressure will be high. Treatment is usually requires neurosurgical review. There could be burr hole and evacuation. So classical history is a chronic subdural hematoma is a trivial trauma, might have been forgotten. Headache could be the first symptom, followed by lethargy, loss of initiation, and confusion. Okay, so this is the episode. So most of the time they can have some lethargy, loss of initiation. So the patient usually visits either a psychiatrist or a neurophysician first, or a physician. So what happens is that the diagnosis is delayed until we do an CT scan. It could be just headache, taken some analgesic for a couple of days, and headache persists. Then only the patient gets a CT scan done, and then you can make out that is a subdural hematoma. The third important bleed is called subarachnoid hemorrhage. Do remember, subarachnoid space is just below the arachnoid matter, and we have the CSF, we have the blood vessel which is passing through the subarachnoid space. So it's most of the time it's bleeding is from the extracranial vessels. Okay, what are the vessels we have? We have all the artery, middle meningeal artery, sorry, the middle cranial artery, anterior cerebral artery, middle cerebral, posterior cerebral. All these arteries are power passing through the subarachnoid space, and most common etiology being a rupture of a berry aneurysm. So the artery which is there in the subarachnoid space already has aneurysm and it ruptures, maybe because of the weakness of the aneurysm or maybe because of excessive blood pressure. Now, the common diseases in which you find this berry aneurysm is usually autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, coagulation of aorta. But for MRCP exam, do remember autosomal dominant polycystic kidney disease, which is one of the causes for chronic kidney disease, can present with berry aneurysm and they can rupture, and patient suddenly comes with the worst headache of his life, what's called as the thunderclap headache. In addition to berry aneurysm, there could be some AV malformation which can bleed. Could be trauma also can bleed. There could be some tumors. Investigation usually CT. CT is usually negative on only 5%. 95% of the time you are able to pick up the subarachnoid hemorrhage. In 5% it may be negative, and sensitivity is low even after 6 hours. Okay, so what to do in such patient where you are suspecting subarachnoid hemorrhage and the CT is not showing pathology? The important thing to do is do a lumbar puncture and try to see the color of the CSF, because in subarachnoid space there is CSF, and the CSF is already CSF is all contains blood. By 6 hours, it would have been changed into yellow color, what's called xanthochromia, because of the conversion of the bilirubin. Okay, so it's called xanthochromia. So that indicates. So these are normal CSF. These are patients with xanthochromia. That means there is some subarachnoid hemorrhage. Such people, you may require cerebral angiogram to identify any aneurysms or AV malformations. What are the complication? Rebleeding rate. So subarachnoid hemorrhage, if it is because of the aneurysm rupture or malformation, it could rebleed in about one third of the patient, and rebleeding occurs in 24 to 48 hours. There could be some obstructive hydrocephalus. That means this blood will obstruct the arachnoid space, and the CSF reabsorption is affected. So the blood gets accumulated within the ventricular system, and you have the obstructive hydrocephalus. There could be vasospasm as well. Vasospasm because of the surrounding blood in the subarachnoid space. What happens? The blood vessels get irritated and they get constricted, vasospasm, which can lead to further cerebral ischemia. How do you manage neurosurgery? No clear evidence over surgical intervention against the delayed. The drug which is commonly prescribed is nimodipine, which is 60 mg fourth hourly. It decreases the severity of the neurological deficit, but doesn't decrease the rate of rebleeding. Sometimes ECG may show some deep T wave inversions and prolonged QT interval. These are features of intracranial pressure, raised intracranial pressure. Okay, so that can be seen in the ECG. So this is a patient with got CT brain, and you can see the prominent whitish hyper densities here. Okay, so these are basically blood which is in the subarachnoid space, which you can be seen. You can see the some blood inside the ventricle as well. So this is about the arterial bleeding. Let's come into the venous thrombosis, what's called cortical venous thrombosis, sometimes called intracranial venous thrombosis. Now these are the dural venous sinuses we discussed in the anatomy, neuroanatomy lecture. So we have superior sagittal sinus, we have the inferior sagittal sinus, which is parallel and below, and all of them, those are in confluence joined together to form what's called as the internal jugular vein, the jugular foramina. So all of them are going to drain to the internal jugular vein. Okay. Now, once these the sinuses are blocked, what happens? Basically, you're blocking the output from an organ. So there's adequate blood supply, but there is no output because you have blocked the cerebral veins because of the thrombus. What happens? There is congestion inside. Okay, congestion, and this hypoxia because there is no fresh blood which is coming to that area. So congestion, and that will lead to what's called as an infarction or hemorrhagic infarction. That is bleeding plus that is infarction. So 50% of patients usually have sagittal sinus. Okay, so this is the sagittal, superior sagittal sinus. This is a sinus which is most of the time thrombosed in patient the case with cortical vein thrombosis. Risk factors are postpartum period. What happens in postpartum? There is usually dehydration because of the severe exertion of the pregnancy and the delivery. Usually, the mother may not be able to keep her hydration. That causes dehydration, and dehydration lead to hypercoagulability, and that can cause thrombosis. That is a reason in postpartum period. Pregnancy is again a procoagulant state, malignancy procoagulant state, and oral contraceptive will again a procoagulant state. So all these patients can develop cortical venous thrombosis. Now, what are the features? Once you have thrombosis, a superior sagittal sinus or any of the sinuses, there is hemorrhagic infarct, which can lead to headache, nausea, vomiting. That could be papilledema because of raised intracranial pressure. That could be seizures. So, any postpartum lady coming to the emergency with the headache, seizure, think about cortical venous thrombosis. That is the high in the list of differential diagnosis in that particular scenario. Now, one of the other veins which is present very quite closely at the base of the brain is called cavernous sinus. Okay, so I think you would have seen here. This is the cavernous sinus. Okay, cavernous sinus is present on either side of the pituitary gland, and it is connected with the few of the veins of the draining the face. Okay, especially lower part of the nose and upper part of the lip, upper lip. Okay, so these are called cavernous sinuses, which are very important. Important of cavernous sinus is there are a lot of cranial nerves and the arteries are passing through the cavernous sinus. So if the cavernous sinus is thrombosed or infected, you have the lot of neural deficit because of the nerves which are passing through the cavernous sinus. So this is the structure of the cavernous sinus. What you can see in the center, we have the pituitary fossa containing pituitary gland or anterior and the posterior part of the pituitary gland. This is the cavernous sinus on either side. So what you can see important structures here. So we have the third cranial nerve which is passing. We have the trochlear nerve. We have ophthalmic nerve. We have the abducen nerve which is passing quite close within the spinuses. We also have the maxillary nerve. Okay, so 3, 4, V1, V2. 3, 4, V1, V2 are in the lateral part. Abducen in the central part along with the internal carotid artery. Okay, so the remember this is a venous sinus which is the called as a cavernous sinus. It has an artery with a nerve, lot of nerves inside it. So this artery, if this venous gets thrombosed or infected, you have a lot of important structure which are affected. And do remember these cavernous sinuses are connected with the veins which are draining the upper lip nose. This is called dangerous area of the face. Yeah, so this is how they are connected. So we have this is the cavernous sinus. So we have the veins, supraorbital, supratrochlear, angular, all these veins. So all these veins are connected with what's called pterygoid plexus. Okay, this pterygoid plexus just be either plexus which is present just behind the maxillary bone, maxillary sinus, and you see that it's connected with the cavernous sinus. So any infection in the lower part of the nose, upper lip can get into the pterygoid plexus and can get into the cavernous sinus. The sagittal sinus thrombosis usually present with seizures and hemiplegia, parasagittal, biparietal, bifrontal hemorrhagic infarct. Cavernous sinus thrombosis could be because of local infection like sinusitis, neoplasia, or trauma. So, because there are important structure within the cavernous sinus, so the patient can come with third, fourth, sixth nerve cranial palsy. So, the patient has probably lost all the muscle nerves which are supplying the extraocular muscle, and patient can come with diplopia on especially an upward palsy because the all the cranial nerves with extraocular muscles are affected here. Cranial nerve 5, especially V1 and V2, that is ophthalmic and maxillary area is affected. So you may have hypoesthesia. That could be central retinal vein thrombosis, swollen eyelids, and papilledema. Investigation of choice for any suspected case of cavernous or sinus thrombosis or any of the sinus thrombosis is usually MR venogram that will be able to strictly identify the thrombosis inside the veins. And treatment here is anticoagulation. Do remember, despite having an hemorrhage and hemorrhagic infarct, the treatment is anticoagulation, which is proven without doubt. So this is a case of cavernous sinus thrombosis where the patient has come with edematous eyelid. You can see there is some erythema, the restriction of the movement of the eyeball. So this is a case called delta sign. Delta sign indicates you can see as delta, which is Latin letter, which is a can appreciate delta sign. Basically, what has happened is this one of these section of the brain which has a superior sagittal sinus, and that is being